All right. So this video really is just parent perspective. Parent talking about having concern early on. Real similar to the story we talked about earlier. 12-month-old, she knew really early on that her child had developed, and just told her, don't worry about it. He's fine. He'll talk when he's ready. And she took him for developmental evaluation at 2, and he was diagnosed with autism. And so that video is on the CDC website as well. So if you head there, you can see that video as well. So if we look then at what all of those early signs and indicators mean for diagnosis, you'll see that the diagnostic criteria has changed and continued to evolve through time. Initially described, Bueller talked about autism in 1911. Initially, you think Connor and Asperger oftentimes are considered really the fathers and coined the diagnosis. And they both wrote simultaneously. Asperger, however, was written in German, and so needed to be translated many years later. And so Connor often gets the credit, but Asperger around the same time period had very similar writings. Both talked about these social differences. I think where there's some different to present day is initially thought to have average learning potential. We now know that about half of children on the autism spectrum have some degree of intellectual disability, which is very different than what we were quoting statistically even a few years ago. That percentage was closer to 70-75%. And so now data really indicates that about half of the individuals have average learning potential. One of the other early misconceptions is that it was a disorder of highly successful fathers. And that's really because no one could afford to travel to Hopkins in Baltimore except highly successful fathers. And so Connor was at Hopkins on the East Coast, and so the only people who could afford to get to him for diagnosis were those who were highly successful. So, I think one of the other major misconceptions was Bruno Bettelheim's theory of refrigerator parents in the 60s, that autism was caused by this insecure attachment, so attachment difficulties between the parents and the child, and specifically mothers. And we now know that also is not true. If we look at DSM criteria, and we're not going to go through all the nitty-gritty nuts and bolts, but want to try to make the argument that prevalence increases matches revision of the DSM. So that early on, infantile autism was a disorder within a pervasive developmental disorder umbrella. With the revision of DSM-3 to DSM-R, the infantile was dropped to include broader age range of children. Pervasive developmental disorder not otherwise specified, or PDD-NOS, was also added at that time, adding a new category of children who were near misses, so to speak, if we want to put it that way. So did not present with all of the criteria of autism, but still had those social communication difficulties, may have a little bit better developed social skill, but they had that repetitive pattern of behavior. Okay. If we look at DSM-4, clearer criteria for autism and PDS were provided there, and a new category, Asperger syndrome, was added again. adding a new population of children, again, with better developed abilities. So in Asperger's syndrome, children or individuals have average language development, and so including talking in sentences by 2, and typically have average cognitive skill. And so those were the criteria. And in DSM-4 text revision in 2000, that umbrella and that spectrum of disorders stayed the same. There was just kind of clarity in how the disorders were described. If we look at the new diagnostic criteria, however, with DSM-5 that came out in 2014, the construct was changed. And so instead of pervasive developmental disorder, we now describe autism spectrum disorder. And that is the diagnostic construct or diagnostic label. And I think it makes sense. If you look at, I don't remember the reference, the authors of the reference, but there have been a couple of recent references from the last 3 or 4 years that describe clinically and research-based, 90% of the publications refer to ASD or autism spectrum disorder in their populations, grouping the population of children together with the 3 diagnoses together in about 90% of the studies. And so changing the construct made a lot of sense. One of the other major changes was the domains of functioning or domains of diagnosis. And so in DSM-4, there were 3 separate domains of functioning in which criteria were measured. Communication, qualitative impairments in communication, qualitative impairments in social skill, and then this restricted pattern of behavior. And if you looked at DSM-4 criteria, many of the bullets or criteria that were under those headings for social and for communication were the same. So it was really hard to kind of filter out those 2 features. And there was some caveat language to say, try not to include the same behavior or behavior exemplar for communication as you do social. And so in DSM-5, this recognizing that core interaction between social and communication skill, those 2 features were collapsed into a social communication category. Restricted pattern of behavior stays the same. One of the other, I think, primary change is in spectrum. So the spectrum in DSM-4 and DSM-4 text revision was using those discrete diagnoses or discrete disorders. So on one end of the spectrum, children who had the most differences in social communication skill and repetitive behavior were autism. And on the other end of the spectrum, we had children with Asperger. And in the middle were the children with PDD-NOS. And so that's how this spectrum of ASD was described. With DSM-5, we now assign a severity rating and describe presence of other conditions. So other differences and other conditions. So if there are genetic conditions, other differences. So quantifying level of language, quantifying intellectual disability. All of these factors are how we now describe the spectrum of ASD rather than having these 3 discrete diagnoses. And so the exact criteria you can read. Again, we're looking for specific behaviors, and specific to me as an occupational therapist, it was interesting to see that sensory processing was now considered one of those behaviors in that restricted pattern of behavior. And so a new symptom was included to add this hypo or hyper responsivity to sensory input. That's widely reported in the literature when children with autism are compared not only to typically developing peers, but to individuals with other developmental disabilities or young children with other developmental disabilities. If you work with individuals who have autism or follow this literature, when DSM-5 was first coming out, there was a lot of debate and a lot of concern that the new criteria was going to reduce the numbers of children on the autism spectrum. And so there were some initial studies to even figure out whether this conceptualization of ASD, despite the fact that the researchers were collapsing those three disorders and using ASD, there were some studies that really looked at whether conceptually that made sense. And this study by Luke Tsai, felt like it didn't make a whole lot of sense that a single category of ASD, given the variability in features and given the variability in differences that individuals present with, it didn't make a whole lot of sense to have this new or changed criteria. Other studies really focused on what the impact will be. What will the diagnostic rates be? And at least this systematic review showed that there were significant and consistent decreases. And this article came out just before the DSM-5 criteria was released. And so they did a reconfiguration of data through the Autism Treatment Network and found that there were decreases in 31% decrease in, if we consider the autism spectrum as a whole, 22% of that decrease from children with autism, 70% of that for PDD and OS. But the new criteria captured those with Asperger's, so that pooled decrease was not statistically significant anyway. But now that the DSM criteria is out, this is really the newest study, came out at the end of last year, and showed that there was a substantial proportion of individuals diagnosed with ASD, via, that PDD criteria really did not meet criteria. And the most substantial changes in rates were among those with PDD and OS, a little bit different here. Asperger's was significant here, or in individuals with intellectual disability. And so I think if we look at individuals greater than 70, and so if cognitive ability was intact or wasn't significantly delayed, so you had an IQ of 70 or greater, those were the children that kind of fell off diagnostically and did not maintain that proportion of ASD diagnosis. And so over time, we're really going to have to see how it shakes out with the prevalence. With each of the administration and entry of DSM criteria, you can see that the prevalence rates have increased. Right now, the CDC quotes 1 in 68. There was investigation came out about a year ago, that said 1 in 50. CDC, however, has maintained that 1 in 68 prevalence because many of the children, the largest age range of growth was in 11 to 14-year-olds who should have been in the sample a few years, 2 years prior when they ran the same prevalence data. And so they're investigating whether we're truly seeing an increase in diagnostics between children 11 and 13, or whether those 11 and 14, or whether those children were just missed in the previous Autism Treatment Network and data surveillance reporting. So if we look at need for evidence-based practices and establishing a need, especially in the Affordable Care Act climate, the Affordable Care Act, I think, in many ways has changed some of the language around disability interventions for those with disabilities or conditions, because it has specific language now that that allows us to provide habilitative care. most insurance and private insurance and even some federal programs really focus on rehabilitative care, so after injury. ACA has some pretty specific language about habilitative care. And if we look at the costs, you can see them here. There's about 3.5 million Americans estimated to have autism, with a $1.4 to $2.4 million lifetime cost. The difference there is intellectual disability. So ASD with intellectual disability, the lifetime cost is 2.4, as opposed to 1.4 if there's not intellectual disability. And the annual cost of care, healthcare cost of care, has been estimated at $236 to $262 billion annually. And so there's this need for evidence-based practices and establishing what those practices are. So, like many, the American Occupational Therapy Association has a practice guideline series where they systematically review the evidence and put together what recommended practices are from evaluation and treatment. They include a systematic review, provide some implications for treatment. I was lucky enough to be asked to drive that publication, and so myself and Christy Koenig, a colleague of mine from NYU, put together this guideline that is actually hot off the press. It just came out last week at our national conference. So if we look at the purpose of the guideline, and well, do you break in this 2 hours anywhere?
If you'd like to.
Okay.
It's up to you.
You know what, why don't we take, I'm just thinking this would be a good stopping point, because once I get rolling on this, it's going to be hard to stop. So why don't we take 5? I've got like 1:56 on my clock here, so why don't we regroup about 2 o'clock, 2:01. So if folks need to run and grab another cup of Java or run to the restroom, you all can do that. So we'll regroup in about 5 minutes.